really delighted to welcome Dr. Chris Armstrong from St James's in Dublin, and this is his first MPN forum, and so I'm offering you a very warm welcome.
Hello everyone. Thank you, Nona, for the introduction. So my name is, as I said, Chris Armstrong. I'm one of the transplant and haematology consultants in St James's Hospital in Dublin. And today I'm going to talk a bit about myelofibrosis because of all the MPN diseases, it's the most likely to come across the pathway of transplant. And I'll talk a little bit about what transplant is in general, and then I'll talk a little bit about some of the new treatments that hopefully will come down the line in time for myelofibrosis. So the outline, we're going to talk about what myelofibrosis is, we're going to talk about some of the symptoms of myelofibrosis, and we've already heard today from John what those symptoms typically are. We're going to talk about how we diagnose myelofibrosis, how we determine the prognosis of this, how we treat it in 2025 in Ireland, what the role of stem cell transplant is, and how we might treat myelofibrosis into the future. So what is myelofibrosis? So not everyone will necessarily have heard of it, but I think many will, even if you don't have it, because we know that myelofibrosis is a pathway that many MPNs can travel towards, although some people are diagnosed with myelofibrosis from the get-go. This is actually a picture of what your bone marrow looks like if you have myelofibrosis, and this is what we call scar tissue being deposited inside the bone marrow, making it hard for the bone marrow to do what it's supposed to do, which is to produce blood cells. So myelofibrosis is part of the family of myeloproliferative neoplasms, and initially cells are overproduced, typically due to the same mutations we've heard about from Dr. Andrews. Overproduction of cells ultimately leads to inflammation, and the bone marrow responds by laying down scar tissue as it would for any injury that you have in your body. But this disrupts the normal factory of the bone marrow. Your bone marrow is unable to compensate for that loss of space and that loss of activity. And to try and compensate, your body will start producing blood cells in other places in your body, typically in your spleen, which has that capability. And that's why patients with myelofibrosis have, typically of all the MPNs, tend to have the largest spleens. So there's three main types of myelofibrosis: primary myelofibrosis, where it's your first diagnosis; secondary myelofibrosis, where you've had a previous diagnosis of PV or ET and have transformed into myelofibrosis; and then a rare entity called pre-fibrotic myelofibrosis, which is in a bit of a gray zone in between, which has some of the features of myelofibrosis, but not necessarily the clinical features. So who gets myelofibrosis, and how many patients do we see a year in Ireland? And typically across the Western world, we see about 2 to 3 patients per 100,000 of the population. So we'd expect somewhere between 50 and 150 people are diagnosed a year in Ireland at various stages of the disease. And that includes patients who have progressed from known previous ET or PV. It's typically middle-aged and older patients who are diagnosed, and the typical age of diagnosis is around 67, but we do frequently see younger patients also. Men and women are equally affected, and about a quarter of patients who have MF have actually had that previous diagnosis before they've transformed. We've heard a lot of what the symptoms are like, and they're very similar to other MPNs, but as we've also heard from the data from the captured in the MPN Voice app, that they tend to be a bit more accentuated. So, but up to 20% of patients with MF are actually picked up on a blood test and are asymptomatic at the time of diagnosis. And for example, if a GP sends a blood to our laboratory and we see their blood cells under the microscope looking like this, we can get an idea that someone might actually have something myelofibrosis, and they may not have known unless they went to have a blood test. Many patients do unfortunately have symptoms at the time of diagnosis though. And these are the typical symptoms we've heard about earlier: fatigue, top of the list, night sweats, itching, bone pain, unexpected weight loss, and fevers. And these are difficult symptoms, and some people have all of them, some people have none of them, some people have everything in between, as we know. And this is a word map showing the type of symptoms that people have described, and you can see the largest one there, of course, is fatigue, as we've heard from before. And just to reiterate that the MPN symptom assessment score that we use across the diseases is also relevant in myelofibrosis, and this is a very helpful tool, particularly when I see a patient with myelofibrosis in clinic, to be able to gauge over time whether their symptoms are progressing, whether I've started treatment, their symptoms are responding to that. So it's an objective measure, as we've heard. But how do we diagnose myelofibrosis? Well, in ways it's very similar to how we diagnose other MPNs. Typically, we do a blood test, a full blood count, which gives us an idea, but the patterns we're looking for are slightly different. So typically with PV, we're looking for that high red cell count and high hemoglobin. With ET, we're looking for that high platelet count. And in myelofibrosis, it can be a mix. But typically, you're seeing patients who have features of MPN, but also may have started to reduce their blood count. So they may become anemic. They may start to lose their platelet counts, for example. So blood tests are the first step, and typically GPs start those, or they may be done in a specialist clinic. That will lead on to do a bone marrow aspirate and trophine, which is then tested for various genetic abnormalities, and sometimes, if needed, we will do imaging of the tummy to look for the spleen size as well. But if someone has a very large spleen, our hands are enough to often diagnose that and to measure it with a measuring tape, as I'm sure some of you may have had done. And this is typically what myelofibrosis looks like. Again, once you've gotten to that stage of having a bone marrow, we can see normal on the left, and you can see it looks very different on the right. So when you're diagnosed with myelofibrosis, it depends on what phase you are in, and thankfully most patients are in what we call a chronic phase, which means that the disease isn't progressing towards a more aggressive type of disease called acute myeloid leukemia. That is, of course, what we're always monitoring for, particularly as patients move through the forms of disease, but thankfully most patients with myelofibrosis are in the chronic phase. As it becomes more aggressive, it transforms into what's called accelerator phase, and then ultimately onto blast phase AML. And we're trying to avoid that. We're trying to avoid that at all costs because we know that we can improve outcomes if we act before that happens. As we've heard earlier, there's different mutations that are associated with myelofibrosis, and they're the same ones for ET and PV. So the JAK2s, CALORs, and IMIPs. And about 10% of patients don't have any of those mutations, but that doesn't mean that they don't have myelofibrosis. So we do special tests to look for those. We do chromosome analysis. You may have seen, if you've ever seen a crime scene TV show, you may have seen things like this on the bottom right, and we do that with the blood cells to see if there's any abnormalities. And then we do molecular testing, and we do a lot of that in St. James's Hospital in a laboratory called Cancer Molecular Diagnostics, and we do special tests to look for various different genes that can affect and be part of the diagnosis. We're always expanding that, so we're learning more about the disease as time goes. So up until late 2010s, we only had 3 different genes we test for. Now we check for over 40 different genes, and that's continuously expanding as the knowledge expands as well. So once we've formed a diagnosis, it's important to determine, well, what's the prognosis? What am I expecting for the rest of my life? How long have I got to live is often a question that patients ask me when they're diagnosed with myelofibrosis. And we have very objective ways of doing that. So they're not perfect, but we have ways of trying to give an estimate to people how aggressive their disease is and what the likely complications are. And these scores are very helpful to decide how quick the disease is moving, what the risk of progression to leukemia is, and whether the patient should be thinking about a stem cell transplant or not. So these scores can give us an idea of whether we should or not. And ultimately, these scores come down to a set criteria. We're looking at patient symptoms, the patient's age, whether you've had blood transfusions or not, how high is your white cell count, are there immature blood cells in your blood, and what are the genetic abnormalities that are in your blood as well. And all those bits of information can be helpful to determine prognosis. And we use different scores. And probably the 2 that I use most, one is called DIPS and one is called MIPS. And doesn't really mean much, it's just an acronym, but they're very helpful for me to get an idea, just an estimate of what the patient's individual risk is. But it is important to remember, these are estimates based on the experiences of a history of a large group of patients. They are estimates only. And within those groups of patients, they are individuals with individual lives. The categories are helpful for choosing the best treatment though, and treatments are continuously expanding. But as testing becomes more sophisticated, we can be more and more accurate, and we are more and more accurate as time goes by, and that will improve. So if we prognosticate a patient and we've given the diagnosis, we then need to decide how are we going to treat it. Probably the most important question, and it's the same with ET and PV, is do we need to treat at all? And there are a proportion of patients with low-risk myelofibrosis who have minimal or no symptoms, have no high-risk biological features, and don't need treatment at all and can be monitored with active surveillance. And by active surveillance, I mean keeping an eye on the blood tests, examining the patients, talking to the patients about symptoms, and then deciding whether they've reached a threshold where treatment might be helpful. But there are a proportion of patients who do not need treatment. Sorry, I'm just reiterating that there. But there are patients, as I said, who do have symptoms, and then we have to tailor our response, our treatments to the individual patient and what those treatments are, what those symptoms are. So some people are very symptomatic of anemia, for example, a low hemoglobin. There are various treatments available. One is called erythropoietin. You may have heard that with people like Lance Armstrong, for example. But essentially, it's a recombinant, or it's a manufactured hormone that is produced normally by your kidneys, and it helps stimulate your bone marrow to produce extra red cells to keep up the red cell count. Some patients will be on red cell transfusions, and there are many patients with advanced myelofibrosis who come to day wards around the country to get red cell transfusions on a weekly or a 2-weekly basis. So that is the reality of some patients' care. There are other treatments like tablets that affect the hormones and how blood cells are produced, and other drugs as well. Often patients have very big and symptomatic splenomegaly. The spleen can cause a lot of compression, it can cause pain in itself. And probably the best treatment for that are the newer agents, the JAK inhibitors. We've heard some about ruxolitinib. But in myelofibrosis, we have additional JAK inhibitors licensed, such as momelotinib and fedratinib, and that we'll talk about briefly. Some patients may have, despite having moved on to myelofibrosis, still have very high platelet counts, for example, and need to stay on hydroxyurea to calm that down. And in select patients with very, very big spleens, there may be some consideration for removing the spleen, which is not done without considerable thought and planning. It's not a common thing that we do, but it can be helpful in very select cases. And in patients who are nearing the end of their life and have very symptomatic large spleens, we can sometimes do things like radiotherapy to the spleen to help to alleviate that symptom. And the other problem, of course, is constitutional symptoms. By constitutional symptoms, we mean things like night sweats, fevers, weight loss, and the JAK inhibitors are probably the best treatments we have for those. So they're the kind of symptom-based treatments. Also, we have to think about the disease activity. So if patients have high white cell counts or platelet counts, for example, we may need to use some of the treatments that we've heard about for ET and PV. Or if patients have progressed more towards an aggressive leukemia, we may need to even give chemotherapy, for example. So it really is an individualized approach to treatment in myelofibrosis. It's important to remember, like in PT and EV, the current approved medications either have limited or no effect on the natural history of myelofibrosis, but they can significantly help with symptom management. And the reality is that the only currently available cure for myelofibrosis is an allogeneic stem cell transplant. And that's an important part of this discussion, because a transplant is not something you would think about in ET or PV, but it would be something that you should consider in myelofibrosis. At the moment, without going to transplant, we think about the available agents, and as I mentioned, the NCCP is reimbursed treatment with fedratinib, momelotinib, and ruxolitinib, so we have choice. And the good news is that the momelotinib, for example, has been licensed in the last year, so new treatments are coming on board after a long period where we had very limited treatment. So ruxolitinib came out at the start of my medical career, and already we've got 3. So hopefully that will continue to snowball, and we'll get more and more treatments as time goes by, because choice is really important. And just really to mention that this is all backed up by a lot of evidence. So we've heard about the COMFORT trials for ruxolitinib that has now lots of mature data on that. So we've over a decade of follow-up on patients who started out in those trials. We have the FREEDOM trial and the SIMPLIFY trials and the MOMENTUM trials. So these are all trials of groups of patients who have proven that these treatments have a benefit. So you can be assured that they've gotten to the stage where we can prescribe them because patients have experienced these drugs and have derived benefit from them. So moving on to stem cell transplant, excuse me. I suppose the first question people often ask is, am I eligible for a stem cell transplant? But it's probably better to reframe that question is a stem cell transplant right for me? because it's not right for a majority of patients. The reality is the stem cell transplant is only required for a minority of patients with MPNs, and that's a good thing, because it's not an inconsiderable undertaking. So the big question I think with patients with myelofibrosis is a stem cell transplant right for me? Is it part of what will help me in my treatment journey? And for some patients that is a reality. But what is stem cell transplant if you haven't heard much about it? So allogeneic stem cell transplant is the only known cure, as I said, for myelofibrosis. But there, as I said, there's various reasons that people won't have one. The pathway towards a transplant or away from a transplant is highly individualized. But everyone with myelofibrosis should have a conversation about transplant with their hematologist. And it may be a very brief conversation to say why it's not the right thing. But I think everyone with myelofibrosis should think about it at some stage during their treatment. So stem cell transplant works by giving blood cells that are the basic building blocks for an immune system from another person to you. Usually it's a brother or a sister or an unrelated matched donor from around the world, and you can see some of the registries that are around the world at the bottom there of people who are willing to be donors. We have almost 50 million people around the world who are happy to be donors for patients. And after a course of immunochemotherapy to prepare the patient for bone marrow to accept the new stem cells, we infuse them and then they start to grow. The new cells find a home inside the bone marrow and they start to produce new blood cells and a new immune system over time. But there's a lot of hard work to get to that stage. Both the treatment that we use to prepare the patient for the transplant and the new cells themselves help to clear up the myelofibrosis and essentially ultimately aim to cure it. So who are the patients who need a transplant? Patients who we know biologically have high-risk disease. So when we check those scoring systems and we determine someone has high-risk disease, those are the patients who are more likely to need a transplant. Typically, transplant is only suitable for patients under the age of 70, however, because there are significant potential side effects that become more and more difficult to deal with as you age. And there are certain lower risk patients who, for example, have very troublesome symptoms or very high transfusion dependency, for example, who may be suitable for transplant as well, but it's always a conversation. And when patients are referred up to St. James's for transplant discussion, we never make a decision on the first go. We always meet patients on multiple occasions and discuss over time whether it's the right option for them, because it's not an easy decision. So many patients will end up in transplant after having a JAK inhibitor, and the best time to have a transplant is when you've got your best response to treatment. So if you're on your JAK inhibitor, you've got high-risk disease, and your spleen has shrunk right down, and you're feeling well, actually we've learned nowadays that that's probably the best time to go to transplant because you're in the best shape possible going into it. But some people will have gone on treatment and it has failed and they have no more options. And in that case, we can still move towards transplant even if the disease is not well controlled, but we prefer to go when the disease is best controlled. Those patients who have very, very big spleens, for example, may need to have additional treatment before the transplant, but ultimately everyone has an individual approach to getting to transplant. In patients who've moved on to more aggressive leukemia, for example, they may need to have chemotherapy first before they go to transplant to clear the disease back down before we move on to transplant. So there's various different ways of getting there. But the realities of transplant are that it's complicated. There's lots of considerations to think. We need to think, who's your donor? What treatment might we use to give you beforehand? Are we going to continue your JAK inhibitor through your transplant? How are we going to manage you and monitor you post-transplant as well? There's a lot of consideration and thought that goes into this. And the reality is that it's not a panacea. We will cure ultimately between 50 and 60% of patients with myelofibrosis. That means that we don't cure up to 50% of patients either. So that is a stark reality. But in patients with very high-risk disease, that may be significantly better odds than if they didn't have a transplant, for example. So as I said, it's considerable commitment, and it does offer a chance at long-term survival in those patients who their disease is likely to shorten their survival. And so we've heard, thankfully, that in MPNs, most MPNs have a near or completely normal life expectancy. So this is only relevant for a select group of patients, as I said. The primary risks involved is that are infection, stress on your different organs, immune reactions, and ultimately, despite going through transplant, about a third of patients do relapse after transplant with their disease again, and that can be difficult to deal with. So Probably the easiest thing to do is to show you. So transplant has celebrated 40 years in Ireland last year. So first transplant in 1984. And we put together this video for the anniversary last year, and it just gives you a bit of a flavour of what transplant is and how it works. And this is all relative to the Irish situation, of course. So I'll just press play. It's only 3 minutes long.
Have you ever wondered how many people are involved in looking after a patient who's receiving a bone marrow transplant? Well, as the saying goes, it takes a village. A patient's journey often begins with their GP, who sends a blood sample to a laboratory for testing. If abnormalities are detected by a medical scientist, the hematology team reviews the results and may order further tests, including a bone marrow biopsy. At the Hematology Oncology Day Centre, patients encounter various staff, including the administration team, nurses, healthcare assistants, and the doctor performing the biopsy. Patient volunteers are also available to offer support. After the biopsy, the sample is sent to specialised laboratories for diagnosis. Once a diagnosis is confirmed, the team devises a treatment plan and the consultant discusses it with the patient and their family. The patient is then admitted to a ward where the pharmacy team prepares the necessary treatment. Initial treatment typically involves chemotherapy. During this phase, there are regular meetings with the bone marrow transplant coordinators and consultants to assess the need for a transplant. If a transplant is necessary, the search for a stem cell donor begins. If a family donor is unavailable, the Unrelated Donor Registry will search the worldwide stem cell registries and identify potential donors. While awaiting a transplant, patients continue treatment, including receiving blood products. Blood donors across Ireland are crucial to this process. On the transplant day, the donor provides either bone marrow collected in theatre or peripheral blood stem cells, which are collected by the apheresis team. They are transported to the laboratory for processing. Depending on the collection timing, cells may be administered fresh or frozen. If the cells are collected overseas, they are delivered by a specialist courier. During the transplant, patients are isolated on Dennis Burkitt ward, receiving care from the multidisciplinary team, including nurses, doctors, dietitians, and physiotherapists. Ward support staff ensure a clean environment and proper nutrition. After the transplant, patients undergo extensive monitoring with daily exams and blood tests, processed in the hematology, biochemistry, immunology, and microbiology labs. Weekly multidisciplinary team meetings review patient progress and address issues. Upon discharge, patients are closely monitored in the Hematology Day ward and join the survivorship programme after 1 year with regular follow-ups. The psychological medicine team supports patients throughout their journey. The stem cell transplant programme tracks patient outcomes, sending data to the European Society for Blood and Marrow Transplantation. The research biobank scientists store samples for ongoing monitoring. Data collection and research, supported by the quality team, drive continuous improvements to help our patients.
Hi, my name is Mark. It's been over 40 years since my bone marrow transplant. I feel very privileged and lucky to thank my brother Steve, my donor, all my family, and everyone involved in St. James's Hospital.
Okay, so I have just 5 minutes left. Is that right? Perfect. Okay, so that's just a flavour of what transplant is. Now, going back, I suppose, to myelofibrosis, and transplant, as I said, is not the end goal for all patients. We think about what's coming down the line, and clinical trials are always the gold standard. So if we have an available clinical trial for patients, we should really be trying to access those. And we're always pushing for access in Ireland. We're a small country, unfortunately, and we don't always get seen for that. But there are many people trying to open clinical trials all the time here. And in MPNs, we have some, we need more. And we should always be thinking, where's the gap? And probably this is a slide from Dr. Andrews from last year, and it showed what the landscape of clinical trial access in Ireland was last year. Those gaps still exist. We need trials for patients who have newly diagnosed disease. We need trials for patients who have had previous treatment and have failed. we need more translational studies. So there are green shoots that is going to change. We have potentially new trials opening towards the end of the year for patients who have failed treatment. We have new translational studies. We have a study in my centre, for example, looking at why patients have clots and why do some patients have clots and why do some patients not. So there's lots of movement in that area, but we definitely need more access. In terms of future therapy, what's going to be the landscape in 5 to 10 years and towards the future? There's lots of stuff on the horizon. There are new drugs for myelofibrosis. There are drugs called BET inhibitors, which can complement ruxolitinib, for example. There are new drugs called LSD1 inhibitors, which are being studied as well. There are new studies ongoing on how we do transplant, so how we improve the outcomes from transplant. How do we bring that a cure rate from 50% to 70%, for example? And other drugs like alternatives. So we know, for example, we have 3 JAK inhibitors for myelofibrosis, but we have no JAK inhibitors for patients who have very low platelet counts, for example. But there are potentially new ones on the horizon that we will be looking forward to. There are specific new exciting things in subsets of myelofibrosis, for example. So patients who have this CALOR mutation, for example, are being studied for antibody treatments that are very specific for their disease. We're looking at patients, new treatments that bring together the patient's immune system to attack their own disease. We're looking at treatments called CAR-T, which you may have heard of, which we do for other diseases in St. James's Hospital. We're looking at vaccine-delivered therapy, for example. So there's a lot of new research on the horizon. Some of it's not going to make it ultimately because it won't have proven itself, but ultimately we have to study these things to get the drugs in the future. So that's all I have to say, and thank you for all your attention.